So let's move on and start talking about junctional rhythms. This is just going to be an introduction to what we need to look forward to in the next couple of lectures, and we're going to try to get an idea and an understanding of what actually happens at the AV junction and the tissues that are surrounding it. So our objectives: describe the anatomic structures that comprise the AV junction, identify the origin of an electrical impulse in a junctional rhythm, recognize the junctional rhythm on the ECG monitor, and understand what happens when the AV junction functions as a primary pacemaker for the heart. So the AV junction itself is very important when it comes to rhythm production and rhythm management. The area surrounding the AV node, referred to as the AV junction, is as physiologically and arrhythmogenically important as the AV node itself. The AV junctional area is located at the base of the right atria near the meeting place of the interatrial and interventricular septum. The AV junction is composed of one or two approaching tracts. Each tract leading to the AV node has its own individual conductive properties. The anterior superior tract conducts impulses very rapidly, so it's also known as the fast tract, and then the posterior inferior tract is slower in conducting impulses and is therefore known as the slow tract. So the tracts approaching the AV node are separated by fibrous and non-conductive tissues and three separate zones in the AV node. So you've got your transitional zone, which is highlighted here in green. You've got the compact zone here, and then you got the bifurcation of the His bundle, which is down here, which is still in the AV junction itself. So the transitional cell zone is the first area of the AV node, and it's a small area of tissue that surrounds the tip of the AV node. It's full of autonomic fibers, and it's very arrhythmogenic, meaning that it can generate arrhythmias. The compact zone is the center or the core of the AV node itself, and it's very similar in structure to the SA node, same type of cells, same cell structure because of its pacemaker function. The compact zone is prone to function as a primary pacemaker, of course, if the SA node fails. And then the third zone is the bifurcation of the His bundle down lower. It's insulated from the rest of the myocardium, and it penetrates the septum there, and then it rapidly conducts the impulses to the bundle branches to where we get into ventricular conduction itself. In about 90% of the people, the blood supply to the AV node is derived from the right coronary artery system. The remaining 10% of people usually have circulation of the AV node that originates in the circumflex artery. Because the right coronary artery is the dominant supplier of the AV junction, myocardial infarctions involving the inferior wall are usually associated with AV nodal blocks and bradyarrhythmias. The inferior myocardial wall is also supplied with blood from the right coronary artery system, specifically the inferior descending artery. So what happens when the AV node fires? When an impulse originates in the AV junctional area, the exact location of the ectopic focus strongly influences the ECG representation on the complex, particularly the P wave. So the impulse would travel from an inferior to superior fashion back up into the atria, stimulating it retrograde. So it would go backwards, and it would actually cause an inverted P wave, especially in leads 2, 3, and AVF when we look at the 12 lead. The impulse would also continue its normal path to the ventricle, so then we would have a normal upright path demonstrated by the upright QRS. So this figure right here, it illustrates the filling of the AV node with water and then opening both floodgates, allowing the electrical impulse to escape. So the illustration here is essentially saying that initially the AV node is closed here, and then those floodgates open up, and they're using that as a demonstration of electricity in between the atria and the ventricles. And when the floodgates open up, i.e. a conduction is created, the conduction will go retrograde and it will go downward as well. As a result, the P wave and the QRS complex would occur at exactly the same time, which would cause the P wave to be buried inside of the QRS. The net result on the ECG strip is that the P wave would rather be invisible or would only account for a small amount of variation in the QRS complex. So this figure right here illustrates the appearance of a junctional complex with a buried P wave. Move some of the ink here so that we can see it better. So the P wave is actually buried here. So one of the things that we're going to see with junctional rhythms is that the P wave is either going to be absent, inverted, or it's going to be post QRS or after the QRS. So this figure right here actually illustrates what would happen from two different areas of conduction or two different areas of ectopic foci. So this area here is actually in the transitional zone and it's up high. The P wave is inverted here because when it fired in the transitional zone, it went quickly up into the atria. Whereas with this, your ectopic area is lower in the system, and so it took longer to get up to the AV node, and by the time it got, it took longer to get to the SA node, and by the time that the conduction got to the SA node, the ventricle had already fired, so that's why it's got a retrograde P wave or a post QRS P wave. So the RP interval, when the P wave is retrogradally spread to the atria and comes after the QRS complex, the RP interval is measured instead of the PR interval. The RP interval is measured from the tip of the QRS complex, which is the R wave, to the beginning of the next conducted P wave. So this is an example of a PR interval that we already know. And this is what it's talking about, the RP interval. Now this is not necessarily something that we will use to help us identify the junctional rhythms, but this is a interval that could be measured. So P waves and QRS complexes and junctional rhythms. The location of the P wave relative to the QRS complex depends on the portion of the AV node where the impulse originated. Locations of the P wave relative to the QRS complex before the QRS complex with a shortened PR interval, such as this right here, you notice a retrograde conducted or a inverted P wave with a very short interval. It could be buried within the QRS, or it could be post QRS, slightly after the QRS complex, like what we were talking about just a minute ago when the ectopic focus is much lower, really close to the bundle of His. When that conduction fires, it goes down into the ventricles and it goes back up into the atria, but by the time it makes it to the atria, the ventricles have already contracted, and so that's why you get the post QRS P wave. And although the intrinsic rate of the AV junctional area is between 40 and 50 beats per minute, you can clinically see junctional rhythms with rates ranging from 30 to over 300 beats per minute. And we're going to talk about our regular junctional rhythms. We're going to talk about accelerated junctional and then junctional tachycardia. Junctional escape rhythm, which is going to be in one of the next couple of lectures, is going to have a rate less than 60 and have some of the key features of junctional rhythms, whereas accelerated is going to be 60 to 100, and then junctional tachycardia is going to be greater than 100. So as we move forward, we're going to identify these junctional rhythms, and a couple of key points about junctional rhythms is that we're going to look for the rate of it. We need to know what the intrinsic rate is, and we also are going to look at how the P wave presents.